Good morning, friends. I'm Dr. Nazar, and in this video, I will show you the handbook illustrating pictures. These all are the pictures and images which are taken from the Australian Medical Council handbook. You will see whenever you will go through this blue book, this is AMC book, you will see these pictures. But here, my this I want to show you here in this video that before appearing in the exam, in a single video or one or two videos you will see, and you will go through these pictures. These pictures will give you the idea. When you will see in the exam, you can easily pick these pictures, and you can answer in a straight way, very in few seconds, because time is very precious in this exam. So we'll go through all these pictures one by one. So this is first picture, which is the molluscum, and this, I'll zoom this picture. This is a self-limiting disease. This is caused by the pox virus, and if these lesions are very giant, we have to check with the immunodeficiency, and if it is it can be there for up to 2 3 years. Ablative therapies are also there, but commonly these lesions are self-limiting. No isolation is needed, but patient should not get take a bath with other peoples, and should not share the towels as well. So these are the lesions of molluscum. Our next picture is the femoral hernia. You can see the swelling on the left side, this below and lateral to the inguinal region. And in femoral hernia, there are highest chances of incarceration. So, and these are very common in the females. Uh, in this swelling, we have to check the tenderness. If in scenario showing this picture and with tenderness is there, then we have to go urgently for the operative room. We have to go for the surgery. If only abdominal distension is there, then x-ray should be done. For example, they have given in this scenario that there is no tenderness, but abdominal distension is there, so we have to go for the x-ray to rule out obstruction first. So this is the this is the picture of the left femoral hernia. Our next picture is the invasive carcinoma of the breast. Here you can see the dimpling, and this is a pure orange shape, and the retraction is also there in the breast. So this is the very clear picture of the invasive carcinoma of the breast. This is the parotid cancer, mucoepidermoid carcinoma, and here, if facial nerve palsy is there, would be there, and pain, skin changes. So CT with contrast is required to get it confirmed. And in treatment, total parotidectomy and lymph node resections would be done. So this is the case of the parotid cancer. Our next picture is the pleomorphic adenoma. This is a benign tumor of the parotid gland, and for this, first investigation is the ultrasound, and then FNA should be done. Base investigation of the, while giving this picture, and examiner is asking about the base investigation, or um, which confirm the diagnosis, then MRI should be the option. Means we have to choose the MRI rather than the FNAC and sono. If it is if they are asking about the confirmation of the diagnosis. And this, you can see this picture, which is involving the ear tragus of the right ear. Here you can see this swelling which involving this right ear, tragus of the right ear. In this picture, this is the image of CT which is taken for this parotid gland, and this is also case of pleomorphic adenoma. CT is very difficult to understand in this stage, but anyway, image can be there in the exam, so we have to see this picture, and then we have to give the answer. So this is the CT of the parotid gland, and this is the chronic parotitis. In chronic parotitis, you will see the fever, pain, and painful swelling will be there. In this picture, first investigation is the sonography, and then CT scan with contrast. MRI in this case is not required, but ultrasound and CT scan should be done. And if stones are there, then hygiene and fluids and pain medicines should be given. And if it is infection, then we have to treat with the antibiotics. So this is the case of chronic parotitis. Our next picture is salivary stones in the salivary gland. This is the X-ray. This means whenever we are suspecting the stones in the salivary gland, then we have to go for the X-ray to get it confirmed. This question is very important. I have seen in the past papers that they ask about the diagnostic investigation about this for this stones in the salivary gland. This picture of the submandibular gland, swelling in the submandibular gland, you can see. I would highlight for the diagnosis of submandibular gland swelling, we have to go with the CT with contrast or MRI and FNAC as well. Mostly these swelling are the cancerous, so we have to be very careful to give the answer. Here, this you can see the peripancreatic pseudocyst. This is the CT scan of abdomen for the diagnosis of pancreatic pseudocyst. So in this case, if it is simple cyst, then endoscopic gastrostomy or duodenostomy is the should be done, and if it is complicated, then laparotomy with cyst excision. So this is the case of peripancreatic pseudocyst. Our next image is the picture is the dislocated anterior shoulder glenohumeral joint, posterior dislocation. Here you can see this picture of the long head of biceps tendon rupture. So if this rupture of the biceps tendon is the proximal, then conservative, and unless athlete. If it is distal, then surgery should be done. So this is the case of long head biceps tendon rupture. Our next picture is the proximal biceps tendon rupture. This is proximal. So as we have seen that if it is proximal, then conservative, unless athlete. In athlete, surgery should be done. If it is distal, then surgery is indicated. If proximal, then conservative treatment. So this is the proximal biceps tendon rupture. This is also called Pope eye sign. This is the picture of allergic reaction. And for the allergic reaction, treatment is the topical steroid. Usually, history of using a topical cosmetics, or sometimes the cosmetics materials are used on the face, and that can also cause such type of allergic reaction. And for the in differential diagnosis, this because rash is on the face, so this can be a malar rash with SLE, we can differentiate, or dermatomyositis. This is also called heliotrope rash. So these can be the differential, but this is the typical case of the allergic reaction. So in history, whenever we see in the exam, the history will shows us that either which one is the most likely diagnosis in this case. Other diagnosis can be there like SLE or dermatomyositis, but if history is very short, then allergic reaction would be the diagnosis. This is STI, external hardulum. Here you can see the treatment is warm compress and hygiene, and this is a commonly self-limited disease. If not better, then cortisol or antibiotic should be given. So this is the external hardulum. This is the chalazion. This is infection of the meibomian. This also called meibomian cyst. So warm compress and hygiene is very important. Resolve in 1 month. If cellulitis, antibiotics, fluoxetine is the drug of choice. If it is abscess, then IND should be done. If it is not responding to the antibiotics, oral antibiotics, then we have to go for the IND. So this is the chalazion. This is a picture of the chalazion. This is CT of the flail chest. First, we have to give the oxygen and analgesics and then intubation. For the flail chest, mostly this is the emergency case. So, with the trauma, this CT has been taken, and we have to diagnose this image if it is given in the exam. Sometimes they may ask about the diagnosis, or sometimes may ask about the first line of investigation, what you will do. So in the flail chest, you have to give oxygen first, then analgesic, then intubation. This is case of squamous cell carcinoma. So here you can see this picture. Excision biopsy is indicated. If it is large or on face, then wide excision with 4 margins means we have to give the excision, it should be wide, and it should take 4 margins in this area. So radiotherapy is also indicated. This is the case of squamous cell carcinoma. This is marginal ulcer. And this history would be like previous history of burn or scar history would be there. It's more invasive. This because of burn. Scar would not be healed. It will take very long. History will be very chronic. This is the marginal ulcer. This is the case of actinic keratosis or solar keratosis, also called. Actinic keratosis is a pre-malignant. It's exposure with the sun can be caused because of the sun exposure. I will try to show you very clear picture. Here you can see Here you can see the rough scaly patches on the skin. So it's also known as the solar keratosis. These actinokeratosis are very common, and they are caused by the ultraviolet damage to the skin. So these are the pre-malignant lesion, and so this picture is very important. And this is the last slide. If you need this soft copy of these images or these pictures, you can comment on in the comment box. So if you anyone who needs, I can give to you. I can share with you the images, and these images are very important for the exam purpose. Hopefully, I'll show you remaining pictures in another video.